Good afternoon, everyone. My name is Nikki Doyle. I'm a partner at KPMG and part of the Health, Ageing and Human Services team at KPMG, and I will be facilitating today's session. The Specialist Dementia Care Program, or SDCP, is an Australian government initiative aimed to support people living with very severe and enduring behaviours and psychological symptoms of dementia, or BPSD. For the purposes of this webinar, we will use this terminology, but please note that BPSD is also sometimes referred to as responsive behaviours. This program will provide a person-centred, multidisciplinary approach to care for people experiencing very severe behaviours due to dementia, who are unable to be appropriately supported by mainstream aged care services. The program will offer specialised transitional residential support focusing on reducing or stabilising symptoms over time, with the aim of enabling people to move to a less intensive care setting. For further information on the actual program, please refer to the Department of Health website. We will have details of the website at the end slide of today's session. The focus of today's webinar is on the program's assessment pathway and the eligibility criteria for the Specialist Dementia Care Program. We have 5 panel members joining us today that I would like to introduce you to, two of whom are consumer representatives. So I have Ron Sinclair, who I'd like to welcome, and Ron has supported his wife Diana, who lived with dementia for a number of years. Welcome to Gina. So Gina assists in the care and support of her dad, who's living with dementia. Gina's dad often presents with severe and enduring behaviours and psychological symptoms and currently resides in a specialist dementia care unit. Next, we have Peter McHale, who is a mental health nurse who has a long-standing career working extensively to improve the quality of life of people living with dementia. In 2007, he won the Nurse of the Year award at the West Australian Nursing and Midwifery Excellence Awards, which was a recognition of his contribution to the field. Next, we have Associate Professor Stephen McFarlane, who is an aged psychiatrist and the Head of Clinical Governance for the Dementia Centre. He has held previous roles of the Director of Aged Psychiatry with Peninsula Health and Alfred Health, and is the current Chair of the Faculty of Old Age Psychiatry. And lastly, we have Professor Henry Brodati. Professor Brodati is a Professor of Ageing and Mental Health and a Director of the Dementia Collaborative Research Centre at the University of New South Wales. He was a founding member of Alzheimer's Disease International and has been the recipient of a number of research, community and other awards. So welcome to all our panellists. We're going to start today's session by talking to Gina. So Gina, you assist in the care and support of your dad Gus, who is living with dementia and now resides in a SDCP. Can you please tell us briefly about the events that led up to his entry into the SDCP?
So Dad had a dementia diagnosis for a few years, and in hindsight now we realise that a lot of the traits that he was displaying were typical dementia and he was progressing. But he would get lost going to familiar places. There was an urgency to get there and then he would forget why he was there. But the most predominant, I guess, was the relationship souring. So he would lose his filter and say things to people who just wouldn't be able to forgive the words, and he lost relationships. But the main event that led to him being admitted into hospital was I received a frantic phone call early hours of the morning that we still don't know exactly what happened, but my mum had been awoken by my dad, who was completely confused, aggressive, completely agitated, and just didn't recognise who she was. And he was so concerned with her being in the house that he tried to physically remove her. So she escaped to the neighbours and they called the police. And through contacting the police and negotiating with them, they were able to suggest taking him to hospital, and that's what I did.
What were your experiences while visiting your dad in hospital, and what happened while he was there?
There were 3 stages of his admission into hospital, and the first was in the emergency room, and then the psychogeriatric ward, and then the mental unit. So each one was progressively worse than the last at the experience. But from the outset, he just wanted to leave. And I think with probably the contribution of some really strong medications that he'd never had before, he was quite a healthy man. They basically confused him a lot more and maybe started to make him hallucinate and digress to another time. So he constantly wanted to go to work. And he wanted to leave. So, for example, in the emergency room, how did he respond? He just wanted to leave. And the response to that was to restrain him with 3 security guards, medicate him, and then isolate him in a room with a mattress and strip him of all his belongings, such as glasses, belts, shoes. There were no sheets on the mattress, and he had to stay in that room with a security guard at the door for 3 days.
How did he relate to the environment that he was in?
Look, because he was regressing in time, he just wanted to get to work, and as his habit was, he used to get up really early hours of the morning, and that wasn't conducive to a hospital environment when you wanted to get up at night, particularly with other patients around. The lights were on all the time, so I think that was really confusing him. As I said, the medication made him more confused and disturbed, I think, in the initial stages, because he just didn't know what was happening to him. And so when he did surge forward or try and get out of bed, he was just creating this complete disaster. And he did this every day, and he tested every door, and he tried to go outside and the doors were locked.
And how did the staff then respond to your dad?
Well, they just had to stop him. So by whatever means that meant, and as I mentioned, they would just restrain, medicate and isolate. He was moved from the emergency room to the psychogeriatric ward, where we thought it would probably get better, but it got worse. So on one particular night, he was trying to get to work, and he seemed to go to a place where he was waking us up as kids, and went into the other patient's room, turned on the lights and said, time to go to work. And that clearly alarmed everybody, including the patients, the staff. And there's no medical sort of assistance during the day. It's only just the night staff, and not often are they familiar with this type of standard behaviour. Or this level. So they called security. Security arrived. Dad was cornered into the corner, and he tried to escape to the courtyard garden doors, and the handle broke, and that's when it just all came to a head. They held him down, called me and said, this is a situation, we have to medicate him, but he has had so much medication that if he has any more, he could possibly die. And then asked me to please provide consent to do that.
That sounds really tough. Can you tell us a little bit about how that has impacted on you?
Well, I still feel, incredibly ashamed that I took him to hospital in the first place. I didn't really think it through. I also had that knee-jerk reaction of, what do I do now? And I thought hospital was the place to help. But I feel really guilty that he had to go through a lot of the suffering while he was in there, because it endured for 6 weeks. When he was in the mental unit, it was even worse. And he was still cognitive to a degree, so it would have been humiliating for him. And I just can't imagine why you would do that to somebody at that age. I really did fear for his life. I thought he would die there, and I prayed that he wouldn't, not there. I didn't want him to die there.
How did you then go about trying to find another place for him?
If I wasn't at the hospital, which I was there every day, I was on the phone. So I was trying to phone all the nursing homes on their area, my parents' area, to be close by, and then my area, anything in between, anything out of there. And I was honest with how my dad was presenting, and people were very, very nice, absolutely lovely. Yet they couldn't provide accommodation for him because the mix wasn't correct. There were older people, frail people, they had a balance in the place and they didn't want to disturb that, or there was no beds. So, a lot of the time I just had, I'm really sorry, dear, but we just cannot help.
So, Gina, thank you so much for sharing your story and for being here today. We might hear from some of the other members of the panel, and then we might come back to hear a little bit more about your story and about your dad, Gus. Ron, thank you very much for being here today. And can you please first tell us a little bit about your wife, Diana, and her diagnosis?
Diana was a very gentle, quiet and dignified person. She was an accomplished equestrian, and she loved animals. She was a terrific mother and a wonderful and supportive wife. Unfortunately, in her early 40s, she started to display some atypical behaviours, and we didn't know what was going on. And over the next almost 10 years, we sought help from a huge range of specialists trying to find out what was going wrong with her. And it wasn't until she was in her mid-50s when she was finally diagnosed with familial Alzheimer's disease.
Ron, could you tell us a little bit about what happened that precipitated Diana's move into a psychiatric unit?
Her, what I call atypical behaviours got worse and worse particularly after her diagnosis. I think she was 54 at the time she was diagnosed. And over the next couple of years, things fell apart. She became gradually more and more aggressive. She kept running away from anywhere at any opportunity. She would break down in the middle of a shopping centre. She would try to get out of a moving car. And there was very little help available to us other than medication. And at one stage, she was on 8 different medications which did very little to interfere with these extreme behaviours. Eventually, we got to the point when she was 58. She was sectioned by her geriatrician under the Mental Health Act and held in the acute psychiatric ward in a local mental health hospital. She entered that place fully aware that she knew that her behaviours were difficult. She was unable to control those behaviours, and she was told that going into that psychiatric ward would sort her issues out.
And what were some of the issues that you saw within that environment?
You'd have to say that it was the most dementia-unfriendly environment you could imagine. It was extremely noisy. The people, the other residents there were mostly pretty violent people. We were not even allowed to see her for many, many days after she was admitted, which would have been terribly traumatic for her, as well as for us. The place was like a cage. There was a small circular hallway, was the only place where people could walk. There was a fenced, secure garden area adjacent to it, but the residents weren't allowed there. That was for the staff to go and smoke cigarettes. The floor, for example, in that place was red vinyl with silver flecks on it, so many of the people were on the floor trying to scratch up the flecks off the floor. The bathroom area had a step down into it, and people who'd lost their perception of depth wouldn't go into the bathroom, so they would relieve themselves in the hallway. As you could see on her photo, she wears glasses. They took her glasses away so she could hardly see anything. She was drugged, and by the time we did get to see her, she was already in a fairly zombie state, and she soon lost her ability to walk and speak.
Do you think if there had been a specialist dementia care program when Diana was in need of additional support, her quality of life would have been enhanced? And if so, how?
I think not only would she have had dementia care, because that wasn't present in the facility, I'm sure that her life would have, her existence would have been very different, because as soon as we got her out of that place after 9 months, and took her off all medication, she became quiet, she quietened down, there was no problems at all. So I think her life would have been extended, she would have been able to function, walk and talk for, I'm sure, a long time, longer than she was. And I think not only for her, but us as a family, we would have all benefited hugely.
So, Professor Brodati, back in 2003, with Professor Brian Draper and Associate Professor Lee Fowler, you developed what is now known around the world as the Behaviour and Psychological Symptoms of Dementia, or the BPSD Brodati Triangle. So could you please talk us through the original purpose of this triangle and what led to its development?
We were seeing a lot of people with dementia and behavioural issues which were not being dealt with correctly. We could see there was fragmentation of services, that the Commonwealth looked after aged care services, the states looked after mental health services, but if you were old with mental health problems, you fell between two stools. And so we tried to think of some way to get some order into this and look at the whole range of different behaviours associated with dementia. There'd been some good epidemiological studies, and we knew from these studies that probably about 60% of people with dementia at any one time will have some behavioural issues. And these could be mild to extremely severe. And if you think about that 60%, we could arrange them in a triangle. So this is the conceptual model for arranging services. It wasn't a way to label people as a 7 or a 6 or a 4. It was a way of the Commonwealth, the state, all of us getting together and thinking about what's the best way to arrange services for them. So now we find, like the Dementia Behaviour Management Advisory Services will come in and help with level 4 and 5, and the Severe Behaviour Response Team with level 5 and 6 and above. And we're now at the point of developing these dementia special care programs to look after people at level 6 who can't be managed in any of the other tiers.
Thank you for explaining that. You've heard a little bit about Gina's story and her dad, Gus. Is this a reflection of all people who are needing services within the aged care industry?
No, of course not. There are some really good news stories and some excellent ways people have been helped with their behaviours, and a lot of staff who are very good at understanding what the behaviours mean, understanding they're often the means of communication, maybe the only means of communication. And a lot of clinicians and aged care staff now know to look for underlying causes before they resort to that. So Gus's story is a very sad story. He wasn't treated well. We wouldn't want anyone to go through that again. And if there are these special care units, then we can avoid going into a mainstream psychiatric unit with young people who are psychotic, often aggressive, often with drug-induced behaviours, is a dangerous place for older people. It's not a good place to be, and staff are not well trained to look after older people at all, let alone those with dementia.
Right. Can you then tell us about what are some of the common issues that aged care providers may experience with people who will need care from a specialist dementia care program?
Well, first of all, they're often quick to move to use of drug treatments rather than trying to understand the problem, understand the person. They often don't have the time, they don't have the resources or the skills. There's a lack, there's sort of family are not taking responsibility for trying to find the best treatment, or if they are taking responsibility, they may have expectations which are unrealistic about what can happen. And so the special dementia care program has the opportunity to provide a specialist resource to assist those working in nursing homes, to assist those being discharged from hospital, or families who are unable to cope at home. But it can never be the first line or even the second line of intervention, because the places will be restricted. It'll be really important to work out a stream, a hierarchy, if you like, of interventions for that person.
Fantastic. Many thanks, Henry. We might then move to Dr McFarlane. So we're here today, Dr McFarlane, to talk about the eligibility for someone like Gina's dad, who is in need of appropriate support, such as that will be provided by the Specialist Dementia Care Program. Can you talk us through some of the key features which will determine eligibility for the program?
Certainly, Nikki, and broadly there are three main criteria that need to be met in order for a resident to be considered appropriate for a special dementia care program. The first is that the behaviours which are causing the referral are related primarily to the diagnosis of dementia, which we're defining for the purposes of this discussion as a progressive neurodegenerative disease. The second criteria that must be met is that the behaviours must be towards the very severe to extreme end of the triangle, as Henry has explained. These units are not for lower level behaviours, which could be managed in mainstream services. The third criteria, and this one is really important, is that the behaviours have proved intractable to adequate trials of routine management. I'd like to spend a few minutes unpicking those three criteria if we can. The first one, that the behaviours primarily relate to the dementia diagnosis. This is a bit problematic when you look at the official nomenclature nowadays, because the term dementia has been officially abolished as far as psychiatric classifications go. It was felt to be a stigmatising term, and in the latest iterations of the Psychiatry Diagnostic Manual, it's been replaced by this concept of major neurocognitive disorder. But it wasn't just replaced in terms of the definition, they broadened the definition of dementia as such to include people, or any people, who had a cognitive impairment that was severe enough to impact on their function and their ability to function cognitively independently. So it was broadened to include people who had suffered a head injury, for example, and as a result had long-term cognitive impairment. It now includes people who've had a neurological insult such as a stroke and have acquired cognitive deficits through that. And it's also inclusive of people who've had a lifelong intellectual disability. So for the purposes of the Specialist Dementia Care Program, we're really focusing on what we'll refer to as the old definition or the traditional definition of dementia, that which is progressive, expected to worsen over time, and that which arises from a neurodegenerative disease such as Alzheimer's disease, vascular dementia or Lewy body disease. That's not actually to say that we're excluding people with comorbid other problems. For example, people with schizophrenia, for example, after many years will develop measurable cognitive impairments. If that person then develops a dementia and dementia-related behaviours, that person is still within scope. But when we're doing the eligibility assessment for the SDC program, we'll be taking a history of the behaviours to try and ensure that the behaviours which are the focus of the referral for SDCP actually relate to the dementia diagnosis, rather than any behaviours which have been long-standingly present and which relate primarily to those comorbid conditions. So the definition of dementia is really important in terms of eligibility. We need to be targeting the people who are at the severe to extreme end of the behaviour spectrum. There are not going to be thousands of beds in the Specialist Dementia Care Program. The number will be in the several hundreds. But with about 400,000 people in Australia at the moment experiencing a dementia diagnosis, we really need to target those who are at greatest need of this very specialist resource and give them the priority for admission. The third criterion is also essential. Henry mentioned that people can move through the levels of the behaviour triangle with time and gave the example of somebody who develops a urinary tract infection. They might previously have had no behavioural disturbance, but in the setting of a delirium could become quite floridly disturbed and transition for a period of time into those very high levels of the triangle. We would expect behaviours that are associated with delirium, however, to settle once the underlying cause is addressed, and they wouldn't meet, therefore, the intractability criteria, number 3 there. We also would expect that all other reasonable management measures would have been taken for a person within residential care to try and settle the behaviours, and for those to have failed, to have been faithfully implemented and to have failed, before we can then conclude that the behaviours are so intractable as to require an SDCP placement as the ultimate alternative.
So just picking up on that point then, does that mean that all people seeking eligibility for an SDCP will already be clients of the SBRT service, the Severe Behaviour Response Teams?
Well, look, you're right in that the criteria for SBRT eligibility also overlap. I mean, the Severe Behaviour Response Team and its cousin, the Dementia Behaviour Management Advisory Service, they also require that the behaviours primarily arise as a result of the dementia diagnosis, not from comorbidities. SBRT certainly targets those behaviours in tiers 4, 5 and 6 of the Brodati Triangle, but we don't require that the behaviours are intractable to accept the referral to SBRT. And in many ways, without the person having been through the process of assessment and a trial of management by SBRT, we can't actually demonstrate that behaviours are intractable because we haven't exposed them to an adequate trial of management. So some of the criteria are similar. The third criterion is different, and there's an important point to grasp here as well, is that not every person in Australia who has severe BPSD will be referred to SBRT. There are many players in this space. We recognise that private psychiatry, private geriatric medicine practitioners, plus a range of aged psychiatry outreach teams and geriatric medicine outreach teams also service this client group. And we realise in terms of applications for SDCP that many of the individuals who are referred will actually have come in through the public hospital system and are probably currently occupying those terrible acute beds that Gina told us about earlier. So you don't have to be an existing client of SBRT to be considered eligible. We do accept referrals from other pathways from within the public hospital system as the primary example.
Okay, so can you tell us then, after it's been confirmed that someone meets the eligibility criteria for an SDCP, what happens next?
Okay, well, there's an assessment process for eligibility which will be conducted by SBRT clinicians regardless of whether the person is currently within residential care or within a public hospital setting. So SBRT will come out to homes and to public hospital wards to do the eligibility assessment using a validated tool so that we can be sure that those three criteria are met: dementia-related behaviours, severe to extreme and intractable to adequate trials of management. Once the approval for SDCP placement has been granted by the SBRT clinicians, the person's name gets placed on a waiting list for the specialist dementia care program within their local area. And the SDCP providers themselves are responsible for managing that waiting list and determining priority for admission to their unit on the basis of the spread of behaviours that are exhibited, goodness of client fit within the current environment and the current resident mix. So SBRT involvement arguably ceases at the point of which we provide the approval for SDCP placement. The process then gets taken over by the SDCP provider.
So as we mentioned today, Gina's dad Gus resides in an SDCP. So Gina, can you tell us about the impact on both Gus and yourself about when he entered the specialist program? And I imagine that the routines of the SDCP were very different to those in the hospital environment.
Sure. So the impacts for both Dad and I were immediate, really, and of great benefit. So just to give you an idea or an overview, we had Dad transferred by patient transfer to, I call it the cottage, and we were following and we were 10 minutes behind. We got caught up in a few lights. So we were trying to hurry to get in there, and you press the doorbell, they let you in, hello, greeted, what have you, and we're walking through the small little hallway into the main area, and I'm looking around for Dad, scanning the room, thinking, you know, that will be the person that's creating the havoc. And he was there sitting having a cup of tea. And it was calm. And there was a lovely smell coming from the kitchen right there. The staff were around giving someone else a biscuit. Someone walking past with a washing basket. So some of the things that I guess within the unit that was so different, what it's very home-like, was it was calm, considering that, you know, it's supposed to be a place where not the best behaviours are displayed by everyone. The staff that were there the first day that Dad was there, were 24/7 staff, still there today. They were there then and they're there now, and they've become really familiar with my dad and the family. there's a garden. Now, I know that it probably isn't as significant to everybody, but for us, Dad wanted to go to work and he was in the fruit and veg area. So when he did show in the beginning, they were watching him and he would get aggressive and say, I've got to go to work. Okay, come and have a cup of tea. Let's go outside and do your gardening. And so there's raised planter beds with herbs and what have you, and he would go out and pick the herbs. And because he was tired, it wouldn't take long before they said, okay, come in. And because it's 24/7 hour care, he's allowed to do it any time of day. They do all the house stuff within the cottage. So they do the cleaning, the washing, the showering, the everything. And it's their own program and their own time. And it also stops a lot of strangers coming through, contractors, and disturbing a homely routine. So it was actually quite a shock to go in there because we thought it could only get worse. We really didn't think it would get better, and it was a nice surprise. And it's not always peaceful, don't get me wrong, but it's just the environment makes it easier. It's a dementia-friendly environment. They're able to walk around without bumping into each other and disturbing each other. And there are a lot of things that are put in place to make sure that they can be independent and live as if it's their home.
That sounds like quite a marked change from where your dad was previously. Can you tell us a little bit then about the staff and how they responded to your dad, as well as you and your family?
So they would respond by looking at him and thinking, okay, what's happening? And they really supported him and they gave him reassurance rather than, I use the word punishment. And they would just reassure and assess and review, and they took the time. Of course, you know, they've got to remove him from a situation, but the environment allows that. So he can go into the lounge room, he can go into the bedroom, he can go out into the garden. And often he spends a lot of time out in the garden. That's the little code we have. Oh, he spent a bit of time out in the garden today. But it keeps him calm and he's happy. And, you know, one of the things they did within a few weeks of him being in the cottage was that they gave him a shovel. And all he did with it was garden. You know, it's a home for him. In the garden, one of the things that they do have is a higher fence, which basically makes him secure and safe for us. He probably doesn't even realise it, but it's one that you can see a duck pond, and there's a second tier to it. So there's a gazebo in it, and we have birthday parties there. So we really are going to see Dad and having a home birthday party in that environment. But the staff have always been the ones to tell me from the very first day what my dad needed. I didn't have to tell them, because they were looking out for him and spent more time with him in his current state and understood him more than probably we did. Yes, the history helps, but they were able to look at him as he walked down the hall and go, oh, he's walking a bit funny today. Let me just have a look. Oh, no, we've called the doctor. He wasn't, there was something a bit amiss. Oh, yeah, he has got an infection. He's got gout in his toe. You know, so they're just really perceptive, but they're allowed to be, because that's the nature of cottage. That's the nature of management all the way down to the staff. It's not something that is in all places. If he doesn't want to have a shower, he doesn't have to have a shower. We'll try again later. Nobody forces you in there. There's not a time. Oh, showers at 10 o'clock. And meals, if he doesn't want to eat that time, they'll do it later. But they come together. They bring everybody to the table. And recently, I witnessed one of the care workers walking with one of the other patients, residents, that just doesn't want to sit down to eat, just wants to pace, and they walk with them and feed them on the go. I can't, you know, and like I said, it's not perfect, but I can't praise them enough for the effort and the trying.
Thank you very much for sharing that. Peter, can we turn to you then? So you've heard about Gina's experience with her dad. You were actually instrumental in the development of the Specialist Dementia Care program, in which Gina's father is currently living. Are you able to provide some further context about what you see are the key features of such an environment?
Yes, thank you. It's a special care dementia unit rather than the programme. The programme's yet to kick off, but it's the forerunner for sure. And I think, Gina, you've probably said everything that needs to be said.
I spend a lot of time.
Behaviours in people with dementia are responsive. And that gives us an opportunity to manage and remove some of those stressors that can occur that can cause some of the problem behaviours to arise. So again, looking at the starting point of the particular special care programme, the building, the bricks and mortar have to be of a domestic, of a homely, of a cottage nature that will give a feeling of comfort and also recognition, that people will recognise that this is okay, this is the kitchen, which is the heart of most people's homes, so that that becomes a focal point for staff and for residents, but also that dining rooms are clearly an area where people will sit and eat when they are able, so that there's no confusion about what rooms might be. Lounges available that will allow people to rest and feel comfortable, that are quiet, with perhaps views out into the garden so that people can be involved in external environments as well. Only through the design and making sure that the buildings manage things like noise, which can be very distressing for people, making sure that we have lighting that is not on 24 hours a day, that we can bring about a normal day-night experience, help with things like sleeping. You know, if you open your door and the lights are fully lit, you don't know whether it's day or night. So those are the sorts of things that the special care dementia units can really take hold of, and will make a bit of a difference and enhance the quality of life for residents. You've spoken about the garden. Gardens are really important, making sure that people can have access anytime, day or night really, but making sure the gardens are safe so people can walk and wander, that there are areas that they can sit and rest, that family members can visit and take them out and be involved in that kind of care. Making sure that the pathways are not dead ends, so that people don't end up in a corner where they struggle to make sense of what's happening and then can escalate behaviours. I think, bearing in mind that the environment will impact on people with dementia, that staff as part of that environment have an ability, if you like, to make it better or worse for people with dementia, in how they approach and how they care for people with dementia. Their response, their attitude, their training, their experience, all of this can have a major impact, both positively and negatively. And I think the things that have been mentioned already about communication, about staff training, about knowledge and getting an understanding of where this person has come from, what the past behaviours, what the work was. Why is he getting up at 5 o'clock? Well, he's getting up at 5 o'clock because he was a gardener or a fruit and veggie man, you know. Or why the night staff or why the resident won't sleep at night is because they've spent 20 years as a night nurse, and you know they're not going to settle at night. But it's about the staff being able to know and be able to manage that sort of and be comfortable about managing that environment. So it is useful to look upon behaviours as being responsive. I think one of the important aspects of providing care to people is to find out as much as possible from family members, almost to be able to share the care if possible. Not always possible, but you know it's helpful if we can establish that relationship and that communication and that feeling of trust between families and staff members. And I know providing consistent staffing, having a roster, if you like, that supports staff, that enables them to take time out and not get overly exhausted or experience burnout, can make a huge difference. Consistent staffing, it's a no-brainer, really. You know, I mean, it's difficult sometimes, but it has to happen, and particularly with the special care programs. I think also that the special care programs are special and need people to lead it. So they need to have somebody who will be able to look at residents, provide hands-on care, to be able to model to care staff, care workers, different approaches, to design, if you like, care packages for individuals, and then redesign them when they don't work, and then go in and help. This is how we might shower somebody, or this is, you know, this is how we are able to dress them. We know we're all creatures of habit, and if you dress yourself in the same way for 40 years, somebody comes along and changes that, then it feels awkward, it feels different, and, you know, it's about knowing these things that will overcome some of the issues. I think the other aspect of the special care unit is probably that it is a transitional unit, and that people do move on. People do frail, they age in place, and they then become quieter or, you know, less troublesome. And it's at that point then that families can have discussions with the team about where is the best place now to accommodate a person. I guess the other thing from my point of view is that special care units are special. They are not an add-on to a dementia unit or you know, an aged care facility. They need to have special staff, special leaders, if you like, within that. And, you know, it's been a long time coming. So we have an opportunity now to really make a good provision of care to these people who are not huge in numbers, but very difficult to manage when they're in the wrong place. Yeah, and just also on the transition, I mean, if you're able to send staff with the resident who's moving to, again, model care to the receiving staff, then that will help that transition as well.
Another question for you, Steve. Is there an emergency option for entry into the unit? So certainly it is quite a concern that people might end up being chemically restrained in hospitals or in other locations, and certainly we've seen commentary around that through the 7:30 report on Wednesday night. How fast will this system actually work, and what happens if there is an emergency out there?
Okay. The SDCP is not an emergency response program. You know, there will not be beds kept free for emergency admissions. In many ways, if we did that, the system would grind to a halt as well. In an emergency, you know, in the case of somebody who has a previously stable condition of dementia, who suddenly escalates to tiers 5, 6 or 7 of the triangle, the logical thing would be to assume that something has upset that person in terms of a medical insult, for example, a superimposed delirium, and there would need to have been demonstrated that there were adequate attempts to manage that underlying condition before the person would even be considered for SDCP. The behaviours have to be not only severe to extreme, but also intractable. So in an emergency, if something flares up without any prior warning, it would be inappropriate to admit that person to an SDCP. The normal emergency services that the residential care facility would normally engage for a similar client would need to be involved.
So will the severe behaviour response teams have clear criteria, such as an expectation around documentation or evidence of interventions to proceed with an assessment? And how will you ensure that the consultant gets it right?
Okay. We have developed a triage process to screen referrals and a detailed assessment process and an assessment tool that flows on from that. We will need to be able to satisfy ourselves when we do the assessments that there has been reasonable attempts to implement the suggestions of the SBRT. The only way that we can really satisfy ourselves that that is the case is by examining the documentation that might support that argument. If we are told that things have been implemented but there's absolutely no evidence from the file that that is the case, that puts us in a bit of a bind, and we wouldn't be able to justify the admission in that circumstance. I gather the thrust of your question was for us to justify the non-admission, but the converse is also true. We do need to make sure that this very scarce resource goes to the people who really needs it, rather than to people who a particular program or facility feels might need it, and we need to have objective and sustainable criteria that we can refer to make that call.
Thank you very much for your responses. So we have come to the end of our questions that have been sent through from our participants. I would very much like to thank everyone for their time today. To our panellists, thank you very much for your insights and that you've provided during the time today. Certainly Hammond Care and the University of New South Wales are continuing to refine the assessment and the eligibility pathways for entry to the SDCPs. And we'll continue to provide updates to the sector via peak bodies and emails. If you have any further questions that you would like to ask or further information that you would like to contribute to this process, you can do so by emailing assessment@dementia.com.au, and that's the email address in the middle of the screen that you're looking at now. If you want to find out further information around the SDCP program itself, you can go to the Department of Health website, which is at the top of the screen that you're looking at now. And if you have any concerns that arise from any of the information that has been contained within the webinar, please contact Dementia Support Australia, and the phone number and email address is at the bottom of the screen, and that is accessible 24 hours a day, 7 days a week throughout the year. So thank you very much again for your participation. It has been a fantastic webinar, certainly I think very interesting and very stimulating. Thank you very much, everyone.